Good afternoon, everyone. I'm presenting a very intriguing case of pseudopapilledema case report. There are no financial disclosures for this presentation. First, a brief introduction. Optic disc edema refers to the swelling of nerve fiber layer at the optic nerve head, and it's always because of some etiology, which can be inflammatory, infiltrative, or compressive. Papilledema term is used when it's bilateral optic disc edema, and it is caused because of raised intracranial pressure. Pseudopapilledema, the term itself is self-explanatory. Pseudo, that means it's false. Papilledema, it gives a look of optic disc edema, but actually there is no true edema of optic nerve fiber layer. So a 42-year-old man presented to our hospital with diminution of near vision. So we just prescribed him presbyopic glasses, and while doing his routine fundus examination, we appreciated that the disc was swollen and raised in bilaterally in both his eyes. So we took a detailed history. There was no history of headache, no doubling of vision, no history of any transient visual losses, and patient was even non-hypertensive. So we conducted a detailed ophthalmological examination. His best corrected distance visual acuity was 6/6 in both eyes, and because the nerve was affected, so we checked the ocular movements nicely. They were painless, they were full and free. Pupillary reactions were normal. His anterior segment in both the eye was normal. To assess the function of the optic nerve, the color vision was tested by Sciarra chart. It was normal. Intraocular pressure was normal. His blood pressure also came out normal, 110/80. So hypertension was as such ruled out. His fundus examination, we do not have the fundus camera with us, so we asked the patient to get it done from outside. These are the pictures taken up from his fundus pictures. So 2D images are not showing exactly, but the disc were swollen, they were raised, and the margins were not exactly blurred, but crenated kind of image they were giving. Spontaneous venous pulsations were not appreciated in that patient. So we advised, we were thinking in terms of pseudotumor cerebri. So we advised MRI brain with orbit to that patient. There was no space occupying lesion found in MRI, and overall the optic nerve didn't show any restricted diffusion, no abnormal enhancement was seen. However, some patchy areas of altered signals were seen in temporal aspect of both the optic nerves, right more than left. So then, because the MRI came out normal, we still referred patient for the neurologist opinion, and then we started having other differentials into the picture. We thought maybe some pseudo disc edema is there, so we thought in terms of optic disc drusen. So we conducted a fundus autofluorescence test, which came out negative. There was no autofluorescent disc drusens were seen. OCT optic nerve head was also done. The OCT optic nerve head did show that cup was obliterated, but the RNFL thickness overall in all the quadrants in both the eyes came out normal. The visual field test revealed no enlargement of blind spot, no hemianopia or no neurological defect, no altitudinal defects were seen. So the neurologist suspected in terms of neuromyelitis optica syndrome, kind of optic neuritis they were suspecting. So they wanted to assess the optic nerve visual function. So they advised VEP and anti-NMO and anti-MOG antibodies, which eventually both the antibodies came out negative. And VEP also showed normal PE100 latency with well-formed and reproducible waveforms in both the eyes. Now, there was no obvious symptoms and signs of raised intracranial pressure. All the tests were coming out normal. So we were also confused. So we thought maybe, we just kept the patient on regular follow-ups. So in case of true edema, why I'm presenting this case is basically in cases of true disc edema, before labeling any patient as pseudopapilledema, you have to do like extensive workup of such patients, because missing a case of true edema can, delay in treatment can really lead to serious neurological complications. The differentials I'm going to discuss will be optic disc drusens, congenital dysanomalies, and pseudotumor cerebri. Pseudotumor cerebri or idiopathic intracranial hypertension is basically a disorder of elevated, the disc edema is because of the elevated cerebrospinal fluid pressure, and there is no known cause for it as such. It's more common in childbearing obese women. Patient presents with headache, transient visual obscurations, and visual losses. Signs will include papilledema with sensory visual function loss and diplopia. Optic disc are extracellular deposits consisting of calcium, hyaline, and other proteins located posterior to Brooks membrane. They'll give, we can differentiate optic disc by simply doing an ultrasound B scan also, because they are calcific deposits and they are autofluorescent. Thank you.
Those costly investigation first.
Sorry, I can't hear you, sir.
So many investigation done.
Yes, sir.
Can you, in your practice, is it not possible in all the cases? Can you cut short the investigation in such in your case, like in your case? Can we cut short our investigation?
Cut short the
Yes,
investigation.
because
Ultrasound.
lots of investigation done, the opinion from neurologists.
Yes, sir. Yes,
And
sir.
frankly speaking, to a neurologist, that fees are all around
I think
1,000.
yes, sir. So I think so two investigations would have helped, like ultrasound B scan, वो optic disc को rule out कर देता अगर मतलब वो calcified था तो होता. Second is FFA, I think would have been a better option. We advised him FFA only, but he ended up getting the fundus autofluorescent, because FFA में अगर leakage होता, disc leakage होता तो वो true edema reveal हो जाता, और अगर वो absent होता तो true disc edema anyways उससे हम रूल आउट कर देते हैं, और उसके फंडस फ्री फोटोग्राफ में हमें ऑप्टिक डिस्क भी रूल आउट होते हैं. आई थिंक दोस टू इन्वेस्टिगेशन वुड हैव हेल्प्ड us better.
And those are basically theoretical. In practical, we can just examine the blood pressure, the physical things, and the optic disc. We can evaluate even every 15 days, every 1 month.
Okay.
If it is enlarged, then we can observe, and 90D, 78, even 60 diopter are most of the time enough.
Alright.
If that vitreous, everything is normal. If no cells in the vitreous, nothing, and pupillary reflex, and in each and every cert, all certs are color vision certs are available. It is very, very important. But color vision, if you can do, so most of the time in papilledema, of course, it N only,
Yes,
the
sir.
N stage, but those are the basic steps before sending patient for a costly investigation.
Okay, sir.
Okay,
Thank you, sir.
yeah.
Thank